I think that these arbitrary regulations that have come about, whether it's the 96-hour rule, whether it's the physician supervision, to keep those in place and just expand Medicaid, as some would suggest a solution would entail. I think we owe our providers a better policy than that out of Washington, D.C., that really entrusts our providers. And so certainly, Shannon, thank you for being here, for traveling from very rural Nebraska to share your expertise, your insight. We know that Brown County Hospital is the only hospital in the county, hence the name. But the county has a landmass larger than the entire state of Rhode Island, and it happens to be next door to Cherry County, that's larger than the state of Connecticut, and it too only has one hospital. So just to try to identify what the issues are here, we know that the critical access hospital designation, I think, is an effective component of our policy. But we ought not assume that every critical access hospital has the same level of care or the same skills that are within that facility or the same community profile. And we need some flexibility. That's why I've introduced the 96-hour rule, as well as the physician supervision bill that would push back there. These are arbitrary. I have a hard time even figuring out how they came about or why they came about. It's that story has not been told. But I do know that the 96-hour bill is a very bipartisan solution with some 70 co-sponsors, very bipartisan, like I said, and these concerns are across America, and I would say even in more urban areas too. Just the impact seems to be felt more at the rural level. Now, there were some questions about audits. I mean, certainly, I assume you have been audited, but just not for the 96-hour, right? Yes, I see strong nods in agreement, yes. So the RAC auditors, I mean, that was mentioned as well. That needs to be addressed. I'm glad that telemedicine was brought up. I think that telehealth probably even adds to the need to address this 96-hour rule that is arbitrarily out there. Do you want to elaborate a little bit on the audits that do take place, Ms. Sorensen or Ms. Saya?
Yeah, absolutely. We have had audits for claims, overall episodes of care. What would be considered RAC, our RAC activity has not been real high, but we definitely have had audits, and these are very laborious. They are intensive in terms of submitting a number of additional supporting documentation, and often for claims that we feel were unnecessarily audited or reviewed to look at in more detail. In all of them, and we have even gone to the level of having to appeal at the administrative law judge level. And the times that we have done that, we have been successful in appealing those, but has not gone without much effort, time, and resources that has been needed to do that. Yeah.
Ms. Saya?
We've been involved with a variety of different audits. The compensated care, as she mentioned just previously, but our RAC audits have not, we have not had a lot of activity. There have been very few small claims, but the time involved with reviewing those, making sure that claims were correctly submitted is very time consuming. We have not been successful in 2 of them in overturning the audit results, but again, the activity has not been extremely high in regards to that.
Okay, thank you. And I do want to certainly emphasize the diversity of critical access hospitals. As Ms. Sorensen said, there's one doctor for the entire hospital, the entire community, the county. Now, some critical access hospitals would have 10, 15 docs maybe, offering a different level of services. So 96 hours of care could mean different things in different communities, and I would hope that we can get our policies to reflect that. Thank you again to our witnesses. Thank you, Mr. Chairman. I yield back.